Hi everyone, my name is Brian Lay, and today I'm gonna discuss about our Module 3A of classes, Health Policy and Bioethics, which is called Economic Issues, Independent Response. So this is the case study. The County Commissioner of all healthcare services in your region has total discretionary power to make budget decisions. The Commissioner has notified you, the Nursing Executive Director, that it has been a lean year and that you must sacrifice some program to balance the budget. You are allotted $1 million for the fiscal year. Decide how the money will be divided among the following project needs. 300 grants for nursing home patients, 100,000 for children immunizations, 250,000 for persons with severe disabilities, 400,000 for AIDS testing and treatment, 280,000 for well child screening, and 100,000 for avian flu prevention. So, how we gonna divide this? So the first question is, how much can you afford to cut from each program without jeopardizing the health of the program recipient? Describes how the theory of distributive justice is applied to budget. So first of all, with children immunization and well child screening, I won't do any deduction. So reduction will increase the risk of outbreaks and maintain early detection of referrals. For a person with severe disability, I would do a 20% cut, which is 50 grants. It helps to reduce non-essential support, shift some service to community agency, avoid cuts to critical care assistive devices. For nursing home patients, I would do around 100,000 cut, which is 33%. Is prioritize direct care and medication, defer facility upgrades, and non-urgent admin. For AIDS testing and treatment, I would do around 200,000 cut. It maintain antiviral therapy for those treatment and high-risk testing, postpone some outreach expansion, and rely on community telehealth. But the risks are late diagnosis, resistant, and we have to monitor closely. And lastly, avian flu prevention, I will have the biggest cut. This is around 80,000 or up to 80%. It just have to maintain minimal surveillance and rapid response on the broad vaccination stockpiles unless threat escalates. So, which program do you consider least necessary, and which group of citizens do you consider least vulnerable? Provide a rationale for your statement. So, the rationale for all the cuts I did before. First of all, the priority is to preserve high-impact prevention and services for the most vulnerable. Children immunization and well child screening are both highly cost-effective. Have to prevent disease, reduce downstream costs, and protect population health as well, herd immunity, and early detection. People with severe disabilities and nursing home residents are also highly vulnerable morally and clinically, so they retain substantial funding. For the other one, larger cuts applied to programs where short-term reduction are less likely to produce immediate catastrophic outcomes, or where temporary targeting can preserve core services. For example, AIDS testing treatment and avian flu prevention. For AIDS services, some non-urgent programs can be deferred and community partnerships maximized. For avian flu, surveillance can be scaled back to essential monitoring with contingency plans. For the distributed justice, we should apply a mixed approach, prioritizing favoring the worst off children, disabled, nursing home residents, utilitarian. maximizing health benefit per dollar via prevention, and egalitarian, which have the complete elimination of any program. This use targeting cuts while protecting core high values target. So how do I feel about having to make these kind of decisions? First of all, my emotional response is going to be distressing and heavy. Making choices that reduce care of services for real people produce moral distress, guilt, and anxiety because harm is foreseeable and sometimes unavoidable. Professional responsibility, I have to bear it as well. I also feel a strong duty to be fair, evidence-based, and transparent. That responsibility motivates prioritization, careful documentation, and active searching for alternatives like grants, partnership, volunteer programs. Also, I will have cognitive burdens because these decisions require weigh imperfect data, competing ethical frameworks, and uncertain downstream effects, which is mentally taxing and increases the risk of error and unintended harm. And then I have to have moral coping strategies to reduce harm and distress. I would apply implicit ethical principles like prioritarian, egalitarian balance, like I said before, use data to guide choices, engage stakeholders and clinicians in the process, document rationale, publicity, and set monitoring contingency plan so cuts are reversible if harm appears. And lastly, as a leadership, I feel compelled to advocate for additional resources, minimize unilateral cuts, and champion policy that reduce the need for such triad like prevention funding, long-term planning. So lastly, would your choices differ if you were a nursing caring for patient in one of the programs? First of all, I will have the perspective shift. As a bedside nurse, my focus will narrow to the immediate patient in front of me, preserving that individual dignity, comfort, and treatment. As an executive, I need to consider both overall result and fairness for all patients. Differences in prioritize is another things. Bedside nurse will advocate protecting services directly affecting the patients, like nursing home care, disability support, opposing cuts that threaten the patient well-being. On the other hand, an executive might allow certain cuts to maintain preventative program with a broad impact. Next is a role obligation. Both roles share advocacy obligation, but the methods are different. The bedside nurse advocates for patient directly through appealing, documentation, crisis escalation. The executive advocates at a system level through budget proposal, policy, and external funding. It is natural and reasonable to experience ethical tension and finding ways to resolve as this is important. Good practice requires mechanisms to incorporate bedside input into executive decision, like frontline representation on budget committees, case reviews, so that allocation choices reflect clinical reality and reduce moral injury to staff. Lastly, the personal impact. If I were the bedside nurse, my emotional response would be more immediate and protective. However, as an executive, it would be broader and more deliberate, but both roles demand advocacy and efforts to prevent harm. Thank you very much.